Hi, my name is Catherine Dubowski. I'm an assistant professor of pulmonary critical care and sleep medicine at Mount Sinai Hospital, and I'm super excited today to be talking to you about asthma and COPD, which are near and dear to my heart. For financial disclosures, just to note that I served as an education consultant for Regeneron Pharmaceuticals, but it should not impact anything in the talk today. And for our objectives for the talk today, I first and foremost am hoping that we're going to really identify the asthma management updates in 2024 using the GINA guidelines, and then use that implement guideline-based treatment for patients with asthma using those guidelines. And then the second half of the talk, we're going to focus on COPD using GOLD to guide our discussion, defining COPD, discussing some of the pathophysiology of COPD, and then implementing guideline-based treatment for COPD patients using the 2023-2024 GOLD guidelines. Really not much has changed in the last year with those guidelines, so the slides you'll see have stayed the same, but it's a big change from prior, so important that we know what the updates are there. In terms of the outline for the flow of the talk, we'll start with defining asthma, the GINA guidelines. I'll introduce you to a patient of mine for help with going through those asthma guidelines. Then we'll jump into COPD with another patient case, going into classifying and treating COPD, and hopefully have some time for 2 board review questions at the end. So, how common is asthma? Talking to a group that already knows this information, asthma affects 350 million people worldwide, claiming over 400,000 lives per year. In the United States, the asthma prevalence is over 8% of adults ages 18 and over who report asthma with current symptoms. And of those 21 million adults, 40% of them report an asthma attack within the past 12 months. So a very common problem, which we all really encounter in our practices regularly. But we know that all asthma is not created equal. So to start with a definition of asthma, it's a disease of chronic inflammation of the airways associated with hyperresponsiveness that leads to recurrent episodes of chest tightness, coughing, breathlessness, and/or wheezing. But there are many different types of asthma, and so I really want us to just take a moment to focus in on this graphic on asthma phenotypes. On the x-axis here, you'll see age of onset, the y-axis is severity of asthma, and you'll see 2 very large circles. Hopefully you can see my mouse here. The one on the left, the Th2, and the one on the right, the non-Th2. Those are basically pretty distinct phenotypes with a little bit of overlap, as you can see, but involve whether there are certain inflammatory markers that we typically see. So to start off with the classic, we have that allergic asthma that starts off a little bit, usually younger in age and diagnosis, can range in severity, a lot of allergic triggers, things of that nature, high eosinophils. We have exercise-induced asthma, also a little bit earlier in onset towards early adulthood. And then the other kind of major category in this group is the late onset eosinophilic, and that includes that subset of aspirin-exacerbated respiratory disease. And then this second circle here for the non-Th2 includes things like very late onset, more common in women, non-Th2 asthma, smoking associated neutrophilic disease. So these are more smokers with neutrophils rather than a eosinophil predominance. We also have the obesity associated and this smooth muscle mediated paucigranulocytic, so not with a specific association of an abnormal cell population there. When we look at these 2 in another way, we think about the underlying cytokines and inflammatory profiles that are triggered in these pathways. So the type 2 inflammation on the left, the non-type 2 inflammation on the right. You'll see that there is a fair bit of crossover at the higher up level, but in the downstream pathways, I want you to focus on things like IL-4, 5, and 13, which are directly in the middle of the type 2 inflammation pathway, and the downstream effects of that being Th2 cells, mast cells, and eosinophils. I've circled TSLP, which is further upstream. It's one of the newer biologics in the population of, in the biologic classes for asthma patients, and it actually does have some non-type 2 action as well. But those are really the characters that we need to consider in type 2 inflammation. In the non-type 2 inflammation, we're talking more about Th17, Th1, and more neutrophilic inflammation. So let me introduce you to my patient to get through these asthma guidelines. Her name is Miss Loda Wiesen. She's 45. She has childhood asthma and allergies. And she presents to you after her third ER visit this year for another episode of wheezing and chest tightness. She says her triggers are seasonal allergies, upper respiratory infections, the cold air, dog dander. She swears cats are not a problem as she hugs her poor cat there. The only med that she's on when she comes into your office is albuterol as needed. When you get some lab work on her, you notice that her serum eosinophils are 600. Her IgE is over 1,000, and allergy testing shows she has both cat and dog dander allergies. The spirometry, when it's blown up a little bit, is a little blurry, but hopefully you can see it here. If this is the first time you've thought about or need a little bit of a refresher on spirometry, I'll just talk you through the way that this is laid out so you have that brief reminder. In terms of the columns, you'll see the reference values listed first, which are based on folks of the same age, height, background as the person we're testing. The pre is the predicted, is the actual measurements of the patient pre-bronchodilator, and then pre-percent reference is what their percent of the reference is. LLN, ULN is lower limit of normal, upper limit of normal, and then we have another 3 columns here which represent post-bronchodilator testing for our patient. In the rows, in the first row, you'll see the forced vital capacity, FVC. That's kind of a surrogate for how much air you can hold in your lungs. And what you'll see here is that for our patient, Miss Loda Wiesen, her number is about 84% compared to the reference, so in the normal range. The FEV1, the forced expiratory volume in 1 second, is 2.35. That's only 71% compared to the reference and is actually a little bit low. As you could see, it's lower than the lower limit of normal. And when we look at the ratio of how much of the air that she, in her full breath, that she's able to get out quickly, we see that that number 71 comes up abnormal here, even though in generally like board answer questions in internal medicine, 70 will be the cutoff for not obstruction, less than 70 obstruction. But in updated reference populations, we realize that it's not a one size fits all. So in clinical practice, we use the upper and lower limit of normal to guide our understanding of if something meets criteria for obstruction. So for this patient, this would in fact meet criteria for obstruction. Then she gets the bronchodilator. We look at her numbers after that, and you can see that her FVC increased dramatically from 3.3 to 4.18, and her FEV1 also 2.35 to 2.96. So a very large bronchodilator response. The proportion of the increase is the same in both, and so her ratio actually stays the same, but that doesn't matter. She's still considered a bronchodilator responder, but she still does have some obstruction post-bronchodilator here. So we'd say this was a mild obstruction with a significant bronchodilator response, and she had complete lung volumes and diffusion capacity, so we can take a look at those results as well. And just to continue the refresher, if you need it, the TLC is the total lung capacity. That would give you measures whether the patient's numbers are low, suggestive of restrictive lung disease, or high, suggestive of hyperinflation. Her numbers fall in the normal range. What we do see in the 1, 2, 3, 4th row down is that her residual volume is the amount of air left at the end of the breath is a little bit high at 141%. And so that means that she does have some air trapping, which is consistent with her asthma. Not always, but can be there. Her diffusion capacity was totally normal. And I've included her flow volume loops here. You can see the blue is her pre-bronchodilator, the red is the post-bronchodilator, and you can see how much improvement she gets after she had the bronchodilator. and the gray shading underneath is the normal range. And lastly, a test that's not too frequently done in the primary care setting, but increasingly common in the pulmonary setting, is a fraction of exhaled nitric oxide, or a FeNO, which is a surrogate marker for IL-13 and is a measure of inflammation in the airways in the breath out when you're breathing out. Normal would be less than 25 parts per billion, and our patient, Ms. Lodewijzen's number was 179, so very elevated. And that's really what we wanted to discuss there. So given that information, we can now look at the GINA guidelines and try to understand what the appropriate treatment is for our patient. There's a lot of information on this summary slide, and so I want us to just break it down a little bit step by step to go through it and make sure that we don't miss any of the big changes that have come up in the past 2 years of GINA guideline updates. So what's always been true is that asthma is a process of constant reassessment, adjustment, and review that's based on looking at how well the symptoms are controlled, what the modifiable risk factors are, checking inhaler technique and adherence, and then looking at whether there are symptoms, exacerbations, side effects, lung function over time, and then reassessing and adjusting the regimen as needed. So that piece is always going to be there. This is the update here. This is the preferred controller and reliever. It's track 1 in the GINA guidelines. And so this is an international recommendation. And as you can see, if you remember old guidelines, there was a step 1 and a step 2, distinct, mild, intermittent, and then mild, persistent asthma. They kind of collapse those two here, saying you treat them both the same, which is not anymore just a low-dose inhaled corticosteroid, but actually a dual ICS LABA, inhaled corticosteroid plus long-acting beta agonist. Their recommendation is ICS formoterol specifically. And then you'll also notice that the reliever is not albuterol or SABA, it's as needed ICS LABA or ICS formoterol, which is definitely a big change from the way that we've been thinking about managing rescue inhalers for our patients in the previous 2 to 5 years and longer. So the question is it time to say au revoir to albuterol? Patients with mild asthma are still at risk for asthma attacks that can be near fatal or fatal, and the triggers can be unpredictable, right? They can include viruses, pollution. SABA use reduces the bronchodilator effect. It can increase your allergic response and increase your eosinophils. And overuse of SABA has been associated with increased exacerbations and increased mortality. So definitely some concerns about the use of short-acting beta agonists. So is it time to say adios to albuterol? Well, I want to introduce you to a new classification called a FABA, or a fast-acting beta agonist, which is what we see here in the red box. So as we know, albuterol onset of action is within 5 minutes. Its duration of action is 4 to 6 hours, which is where we get a short-acting beta agonist. For formoterol, which is the LABA in Symbicort, the long-acting beta agonist, because it lasts 12 hours, but it actually has an onset of action as 5 minutes, just like albuterol. So if we were to say fast-acting beta agonist, both albuterol and formoterol would meet that criteria. I just included salmeterol here to show you that this is not a fast-acting beta agonist, and this would not be something that could be used in the same way as a rescue pump. So if a patient has Advair or Wixela, the onset of action of that medication will be 30 to 48 minutes. It will take far too long to be used as a rescue inhaler. So is it alvedosane to albuterol? Well, a new pump came to the market in the past year or so. It's the first FABA ICS rescue inhaler approved by the FDA. It's called AirSupra. It's a combination of albuterol and budesonide, and it is available now. It often requires a prior auth, but is not hard to get. You just say that the albuterol isn't working, and then generally the insurance will give the okay for this. And so they're marketing this as like their first in class, and it's just so revolutionary. But the reality is this has existed and been very thoroughly studied, and that's why it's existed in the guidelines in the recommended pathway now, because of all the work that was done with Symbicort or budesonide formoterol in order to use it both as a single pump for both maintenance and reliever therapy, or the SMART strategy. The only difficulty in the United States is that Symbicort or budesonide formoterol is not FDA approved for this indication, and if a patient were using it regularly and additional doses as their reliever therapy, they'll run out of meds too quickly and may have trouble getting refills of the pump. So we just need to be mindful of that. But this theory of inhaled corticosteroid plus beta agonist has been around for some time. And when we look at this Cochrane review, which is looking at FABA alone, so here it would be albuterol versus as needed FABA ICS, you'll see that in the difference in exacerbations, there were decreased exacerbations. Here's the odds ratio. There were decreased hospitalizations, ER or urgent care visits. There was some crossover in the group. So some of the folks in the as needed FABA did end up getting some inhaled corticosteroid, but significantly less than the FABA ICS group. The total oral steroid course was significantly reduced, which is good, and adverse events were equivalent. So very safe and effective in that sense. There is this alternative track 2, which is basically, I think, in part here for the United States, because we haven't really had the options to make this transition into the ICS formoterol pathway very easily. So here we keep step 1 and step 2 separated, but basically the maintenance is the same, which is when you're taking your inhaled corticosteroid, you should also take your SABA. So you basically create an ICS plus or FABA or SABA, and the reliever could be as needed ICS SABA or just as needed SABA, where you take it every time you're using your inhaled corticosteroid. So this pathway is the alternative and what might be easier for some of our patients to obtain, practically speaking, with their insurance. I didn't go through the higher steps. Those haven't really changed much. You'd step up your therapy from, low dose to medium dose to high dose inhaled corticosteroid. Once you get into more severe asthma, you're thinking about those phenotypes on how to target the inflammation, whether it's IgE, IL-5, IL-4, or anti-TSLP in the right patient. At the bottom, you can see here these other controller options. So that might be leukotriene receptor antagonist, immune therapy for allergies, or possibly the addition of azithromycin or low-dose oral corticosteroids. But when you're kind of in that high steps, these are definitely folks who should be co-managed, I think, by pulmonary. And if we think about Miss Loda Wiesen, she should definitely have been on a controller therapy given her frequency of exacerbations, and would then need that reassessment over time to figure out how high of a dose she needed and adjust it up or down depending on her symptom burden. So takeaways for asthma. We have asthma is a syndrome of chronic airway inflammation with bronchial hyperresponsiveness, leading to symptoms of chest tightness, cough, breathlessness, and or wheezing. There are multiple types of asthma, including those with type 2 inflammation, allergic or eosinophilic asthma, and those without, like obesity-associated neutrophilic and late onset non-allergic. As needed, FABA ICS inhalers reduce exacerbations, ED visits, and hospitalizations for all asthma compared to FABA alone, and really should be the way that we move our patients to help them get the best possible care. All right, that was the whirlwind of asthma, and now I'm going to step into COPD. So in order to do that, we'll start with a little bit about numbers about COPD. COPD was the 3rd leading cause of death worldwide, with 3.23 million deaths in 2019. I know this data is a little bit old. I actually could not find more updated statistics. Obviously, in 2020, the world changed. This was some US data, which was through 2020, showing COPD as the 6th leading cause of death in the US, with 152,000 deaths in 2020. And what's really the most staggering is the fact that COPD is underdiagnosed and underreported as a cause of death in the US and internationally, which means that these numbers are kind of gross underestimates of the severity of the problem. So to talk more about COPD, I'd like to introduce you to my patient, Miss Emmy Zima. She's 66. She's a former 40-pack year smoker. She has daily shortness of breath. Her exercise tolerance is about a half block, limited by her breathing. She has daily cough with clear sputum and 2 to 3 exacerbations per year. I have her spirometry pulled up here, and now you guys are experts at spirometry. I've put the asterisks here to say that this was a post-bronchodilator spirometry, so you can see these are post-bronchodilator numbers. Her forced vital capacity was 98% compared to the reference. Her forced expiratory volume in 1 second was 29% compared to the reference, less than a liter. And her ratio, the FEV1 to FVC, was 23. I've included her flow volume loop here and a normal on the right, so you can take a look. Nice, normal, similar rounded breath in on the bottom. Above the x-axis, we see these very scooped out shape of her flow volume loop compared to the normal blue line here. And you can see how far below the range she is in her flow volume loop. So how do we define COPD? Well, this is actually a new definition for the 2023 guidelines. A heterogeneous lung condition characterized by chronic respiratory symptoms, dyspnea, cough, expectoration, and/or exacerbations due to abnormalities of the airways, could be bronchitis, bronchiolitis, and/or alveoli, such as emphysema, that cause persistent, often progressive airflow obstruction. So it's kind of a mouthful. What's interesting to note is that what's no longer in this definition is exposure to noxious fumes or toxins. That was considered a part of the diagnosis, a part of the definition before. But we see that that's been omitted, and I'll explain in a moment why that is. But really the definition boils down to these 3 things. So respiratory symptoms, airway or alveolar abnormality, and the airflow limitation, which is defined as a post-bronchodilator FEV1 to FVC of less than 0.7 or 70. That's GOLD guidelines. So for the diagnosing in COPD, if we're using GOLD, we use that strict cutoff, not those variable numbers that the reference values may provide. Radiographically, emphysema comes up here as a possible component, but is not a requirement, which I always think is interesting, but I think in part because GOLD is meant to be a global guideline, that there's a lot of the world that doesn't have access to the type of imaging that we're getting, and so we don't want to make that a requirement for diagnosis. And there's variability in who actually has radiographic emphysema as opposed to just obstruction on their pulmonary function testing. This is why the toxin, the exposure piece was taken out. So this is the new proposed taxonomy for COPD. And you'll see here that it's a really much more inclusive definition than it had been prior. So to provide a quick example, down at the very bottom, the second from the bottom, COPD asthma, COPD-A would be someone with childhood asthma that has a chronic obstruction because of their asthma. Like actually Miss Loda-Wiesen had an obstruction even post-bronchodilator. So there may not be an exposure there at all other than maybe their asthma. The classic COPD I think that we all think of is environmental COPD, which would be cigarette smoke, COPD-C they propose, or biomass or pollution exposure, COPD-P, where it's more about those exposures. But it also includes things like COPD due to infections like TB, HIV, which would be COPD-I, genetic determinants like alpha-1 antitrypsin or other genetics that would cause a genetic change such as COPD-G, or due to abnormal lung development such as those preemies who end up developing COPD because their lung function never reaches a normal, catches to a normal trajectory in the development. So COPD due to abnormal lung development, COPD-D. I think the field is still trying to wrap their head around this. I don't think this has been widely accepted yet, but it will be interesting to see how it plays out in the field going forward. To talk a little more about the pathophysiology of cigarette smoke, because I think this is something that is very probably board testable, but also just important in the way we think about treatment. Cigarette smoke affects both the innate and the adaptive immune response mechanism, and it's causing prolonged inflammation, alveolar destruction, and airway remodeling. In terms of the innate activation, we see neutrophil, macrophage, Th1, Th17, lymphocytes, which are activated, leading to fibrosis and mucus hypersecretion. And on the adaptive side, we see the activation of dendritic cells, which lead to decreased T regulatory cells, which normally suppress an excessive immune response. And so this is a schematic showing some of those downstream pathways here. With the cigarette smoke, you can see the dendritic cell, the more adaptive immune system, with the CD8 T cell here, more so than the CD4, but with downstream effects of Th17, Th1, and causing mucus hypersecretion, alveolar wall destruction in that pathway. And from the DAMPs and PAMPs, you can see the activation of macrophages with some of the inflammatory cytokines that are triggered there, which can lead to fibrosis and some of these other downstream effects. So now that we've covered some of the basics, let's talk about classifying and treating COPD with the time that we have left. So it's important that we come up with the standard classification or use the standard classification of GOLD in order to really understand who we're treating and how to treat them. We have three components of that classification. We need to understand a patient's degree of airflow obstruction, their symptom burden, and their exacerbation history in order to put that classification together. So to start, you're going to look at, once you've confirmed the patient has obstruction, on a post-bronchodilator pulmonary function test or spirometry, you're going to look at the severity of that obstruction based on their FEV1. If it's greater than 80, 50 to 80, 30 to 50, or less than 30. And then you're going to look at their symptom burden. And there are two ways we typically do that. One would be the MMRC, which is a scale. I wish that I could draw stick figures this well. This is that I borrowed from a blog, which I've credited here. But a grade 0 would be not dyspneic unless you're really exerting yourself. Grade 4 is very dyspneic, just moving around in the house. We'd say that 2, 3, or 4 would be folks who are more symptomatic. And then the other symptom questionnaire that we use is the CAT, the COPD assessment test, which grades 8 questions on a scale of 0 to 5 in order to determine higher numbers, more symptomatic, as a second questionnaire. And then the last piece of the puzzle is the exacerbation history. So how many exacerbations per year and how many hospitalizations secondary to exacerbations? And this is one of those things that I think the field is still trying to come up with better ways of identifying exacerbations, because we've all seen that patient who has the CHF versus plus or minus COPD exacerbation, and there's a lot of overlap. But we think of exacerbation as a change, right? It's an acute change, not the subacute slow decline. It's a change that is notable in their symptoms, more shortness of breath, coughing, phlegm, things of that nature, and causing a change in your treatment, stepping up your nebulizer treatment, starting prednisone or antibiotics. So you need all of those in order to meet criteria for an exacerbation. Once you've gathered all of that data, you're going to use this assessment tool, which feels like a lot of information, but it's everything we've already talked about, right? So you've proven the post-bronchodilator ratio is less than 70 or 0.7. Then you look at the severity of their FEV1 to come up with the grade. And then you look at this little plot here where on the x-axis we have symptoms, where more symptomatic is higher up, and the exacerbation history on the y-axis, where the increased exacerbations or more severe exacerbations greater than or equal to 1 leading to hospitalization would be higher up on the y-axis. And then The biggest point that I want us to note here is how this ABE is actually a big change from our prior classification, which was ABCD. And that really has to do with the fact that exacerbators are exacerbators. And I tell my trainees that if you are exacerbating frequently and in between those exacerbations tell me that you're ready to run the New York City Marathon, it doesn't mean that you go off of your therapy. You still need to stay on therapy because you are at high risk of exacerbation in the future if you had recently exacerbated. So instead of having like a C and a D for how symptomatic you are, we realize that this just needs to be E, exacerbator. And when we look at our patient, Miss Emizima, we know that her FEV1 was actually 29%, so she's gold 4, and she has multiple exacerbations a year, so she's a 4E, which will come in when we think about next steps for her. So why do we go through all of this like mental gymnastics of gathering all this information? Well, it predicts outcomes, and that's kind of a vague term, but what are we predicting? Well, we're predicting some aspects of survival, likelihood of exacerbations in the future, lung function decline. This is a graph just showing as the FEV1 severity increases, the probability of survival goes down. But it also is going to guide our treatment. So that's really important, that if we haven't done this piece of the classification, then we are starting kind of guessing as to where we should put our patient on therapy. So after you've done that A, B, or E grouping, you're going to use this graphic, which is the initial pharmacologic treatment, in order to start your patient on therapy. And what you'll notice here, if you remember from our prior guidelines in 2022, that we used to have LAMA as the backbone of our therapy. Group C, D, and B all could have been started just on solo LAMA therapy, which is not the case in the current guidelines. Well, where did we get this obsessed with LAMAs? It was the Uplift trial, which is getting kind of old now, 2008, but is still a landmark trial in COPD. Almost 6,000 patients randomized to placebo or tiotropium that were followed for 4 years. And what they showed was that the tiotropium group had a decreased probability of exacerbation with a 16% reduction in exacerbations. And so that was pretty good. And so from there, we felt like everybody with COPD should be on a LAMA if they're at all symptomatic to reduce the likelihood of exacerbations. But as you can see, the LAMA-LABA is now the standard recommendation in the 2023 and 2024 guidelines, and we want to know kind of where that data came from. Well, this is a meta-analysis from 2022 looking at a number of studies comparing LAMA-LABA dual therapy to LAMA monotherapy on these 6 parameters: lung function, dyspnea, exacerbations, exercise tolerance, quality of life, and pneumonia. And what you can see is that at least 4 of them, the green here represents LAMA-LABA did better than solo LAMA therapy in lung function, dyspnea, exacerbations, and quality of life. So significant improvement in dual therapy over monotherapy. For exercise tolerance, it was equivocal, like the same, possibly. Pneumonia, about the same. There was nothing red, which would have been dual therapy performing worse than monotherapy. So with this level of data, it makes sense that we should start our patients on dual therapy. So that's where we get the dual therapy. And then the question becomes, well, where does the inhaled corticosteroid fit in, right? So that goes back to the TORCH trial, which was over 6,000 patients who were randomized to either ICS-LABA, ICS alone, LABA alone, or placebo, followed for 3 years. The graph here on the right is showing change in FEV1, so they had better lung function, but they also had decreased exacerbations. Using ICS-LABA decreased exacerbations by 25%, with a number needed to treat of 4 to prevent 1 exacerbation in a year. So why don't we put all of our patients on inhaled corticosteroids? because of the fact that we also saw a very significant increased risk in pneumonia in those receiving inhaled corticosteroids, 49% increased risk of pneumonia. So we needed better guidelines for how to break out who to give the inhaled corticosteroids to, and GOLD has provided that for us here by summarizing the data nicely. If you are someone who's been hospitalized for exacerbations, have greater than or equal to 2 moderate exacerbations in a year, a blood eosinophil count over 300, or concomitant asthma, you benefit from inhaled corticosteroids. You should avoid steroids in patients with repeated episodes of pneumonia, low blood eosinophils. This would be off of corticosteroids, and then with a history of mycobacterial disease. So when we think about our patient, Miss Emizema, we see that she presumably would be started on LAMA-LABA therapy. I didn't tell you what her blood eosinophil count is, but we have these pathways for stepping up therapy, which are very useful in the GOLD guidelines, one being dyspnea, the other being exacerbations. We'll focus more on the exacerbation pathway because there's a little bit more to it. But after stepping up therapy, at least to dual therapy, then to triple therapy, if the patient is still symptomatic, then we have options of roflumilast or azithromycin, depending on the patient. So this would have been the pathway for Miss Emizema, and after she's on triple therapy, we had to figure out what to do next. So just a quick slide on the mechanism of action of roflumilast. It's a PDE4 inhibitor, and so it increases cyclic AMP, which slows epithelial remodeling and fibrosis, causes bronchial smooth muscle relaxation, and also macrophage and neutrophil downregulation, all good things. And so the REACT trial showed that nearly 2,000 patients were randomized to either placebo or roflumilast if they had, they had to have severe airflow obstruction, chronic bronchitis, and at least 2 exacerbations in the past year, and they were followed for a year. And they showed a reduction in exacerbations of 13% in the roflumilast over the placebo, which is also really impressive. In azithromycin for the prevention of COPD exacerbations, an azithro study, which I think they really could have called the ape study since we're on the animal theme here, but nobody asked me. Azithromycin for the prevention of exacerbations showed that there was benefit for azithromycin as well. And the mechanisms we know, aside from being directly antimicrobial, it also blocks the leukotriene chemokine response, which then triggers neutrophil adhesions and migration into the airway and causes epithelial injury. So has multiple mechanisms in which it works. And when we look at this study's data, it was over 1,000 patients randomized to azithro or placebo, followed for a year, and you can see proportion free of COPD exacerbation. The azithro group performed significantly better. The number needed to treat to prevent 1 exacerbation was 2.86, so pretty good data for using azithromycin. There is no head-to-head comparison out yet. That study is ongoing. We hope to have some answers as to how to think about these 2 head-to-head, but for right now, we have some subgroup analyses, which I won't go into today. After you've completed this pathway and you've put them on roflumilast or azithro, if they're still exacerbating, I've had this patient like Miss Emizema come into my office all the time and they think that's it, right? There's nothing left for you to offer me. And that's really not true. We have advanced therapies for the right patient. So we could consider something like a bulectomy if the patient has really significant bullous disease, surgical or bronchoscopic lung volume reduction to try to reduce the hyperinflated lung and therefore allow normal lung to do better gas exchange. Biologics are just around the corner. I think we're about to see the FDA approval of the IL-4s in COPD, and obviously lung transplantation in the right patient. And no talk for COPD is complete if you really don't take a moment to think about all the things that I know this population, this audience is very well versed with, right? These are really where a lot of the gains are made, discussing vaccines, smoking cessation, and low-dose lung cancer screening in the appropriate patients, referrals to pulmonary rehab, supplemental oxygen and non-invasive ventilation when appropriate, and remote monitoring, which is a newer technology which is still being tested for benefit, but gives us a lot of additional monitoring for our patients to hopefully keep them out of the hospital. I've included this graphic from it's the European Respiratory Journal, showing that really the biggest bang from your buck comes from talking about the flu shot and getting the flu shot for patients, way more than triple therapy and telehealth and all of this. So smoking cessation, flu shots, pulmonary rehab really make up the base of this pyramid for our patients. So just to kind of wrap that up, our COPD takeaways. The GOLD guidelines define COPD as airflow limitation in patients with respiratory symptoms and airway and/or alveolar abnormalities. The new proposed taxonomy highlights the multiple causes of COPD, including environmental, infectious, and genetic drivers. Cigarette smoke-related COPD is a manifestation of innate and adaptive immune responses that result in fibrosis and mucus hypersecretion. We know patients who are symptomatic, who have COPD, benefit from at least LAMA-LABA dual therapy. Inhaled corticosteroids are not for every COPD patient, but in the appropriate patient, they can be very helpful, and that we should consider roflumilast or azithromycin for patients on maintenance therapy with continued exacerbations. And then don't forget the non-pharmacologic basics: smoking cessation, vaccines, pulmonary rehab. And lastly, with the last few minutes we have here, I just want to run through 2 board review questions with you. So, question 1. A 70-year-old man with a 30-pack year smoking history presents to the office with shortness of breath and decreased exercise tolerance over the past few years. He notes intermittent wheezing and non-productive cough. He's treated with bronchodilators with improvement in his cough and wheeze. His post-bronchodilator spirometry is pictured below. Which cell type is usually involved in the suspected diagnosis? So from the question, you can gather we're talking about a smoking history, post-bronchodilator spirometry showing a nice obstructed loop. So we would say that likely this patient has COPD. In terms of the cell types that are involved, well, even though there are some eosinophilic COPD, we're really thinking of like the majority of our COPD patients, which are more neutrophilic and CD8 positive T lymphocytes. We'll see that was represented here in this graphic, more heavily CD8 T cells affecting Th1, Th17, Treg cells. A small percentage will have that eosinophilic phenotype, but that's not the majority. And lastly, question 2. A 55-year-old woman, never smoker, presents to the office for evaluation of intermittent wheezing and shortness of breath ongoing for years. She has nighttime wakenings with these symptoms, especially when she's suffering from an upper respiratory infection. When asked about medication allergies, she reports that she doesn't take ibuprofen because it makes her short of breath. What additional evaluation should this patient have? So in the question, we can gather that we're probably talking about somebody with asthma symptoms and never smoker, so probably not trying to get at COPD is the diagnosis here. Obviously, there's something to the ibuprofen, and really what the question is getting at here is aspirin exacerbated respiratory disease, or AERD, which is a subtype of asthma with the Samter's triad, right? So asthma, NSAID intolerance, and nasal polyposis or sinusitis. So an otolaryngology and ENT consultation to evaluate for nasal polyps could be very useful here because it could help guide treatment for this patient. And that concludes our Whirlwind Asthma COPD updates. I hope that it was helpful, and I wish you the best of luck in the board review process. Thank you.